Hello, everybody. It is good to see you this evening. We have a very special treat. We are having Dr. Brittany Lamb come and share with us exactly what we should do for dementia type emergencies. That can be so stressful and something that honestly no one talks about. But before we bring Brittany on, I want to let you know, in case you don't already know, that on September 17th through the 21st, we are having a free Zoom workshop called How to Stop the Four Most Common Challenging Dementia Behaviors. If you feel like you have been isolated in these weird situations that, quite frankly, you're like, I signed up for memory loss. I did not sign up for them asking to go home or them constantly accusing you of things or that nature, go to the link in my bio. That's where the sign up is at. So with all that being said, all right. See her trying to get in. I'll invite her as well, see if that works. So welcome, everybody. Hi, Brittany. Welcome.
Hi there, it worked. I'm
All
here.
right. Yeah, I know. Easy peasy lemon squeezy.
Yeah.
All right. Yeah, I'm sure you guys can relate. Sometimes the technology can be a little. Yeah. So introduce yourself.
Yeah, so hi
For
everyone.
those.
Hi everybody. My name's Brittany Lamb. I'm an emergency medicine physician in the nighttime. But here online, I help educate people how to navigate the medical side and healthcare side of advocating for someone when they're living with dementia.
Awesome.
Yeah.
Awesome. Yeah. Well, we're excited to have you because I don't think this is something we talk about a lot. Kind of like I was just saying before you hopped on that oftentimes when caregivers get thrust in the situation, if they're family caregivers or even professional caregivers, you think you're getting memory loss, but what you're actually getting is a whole host of things,
hmm
which I'm sure you've seen in the ER. So
hmm
I guess share with me what is some type of dementia emergencies that you see.
Yeah, so the two most common reasons I see people living with dementia in the emergency department are one, falls. That's super common. And then
Mm,
the other thing is a change in behavior, a change in mental status. That's what we kind
mm,
of, this umbrella term we use, which can be anything from a new medical problem that they are currently having. It can be due to a medication. It could be due to changes due to dementia and maybe someone hasn't seen them in a while. Maybe they didn't sleep enough, and there's just so many reasons why they could have a change, but people get worried about that. And so a lot of times these days you can't get in to see your doctor, and so people come to the emergency department quite a bit. But from living facilities, I see a lot of people who fall with injuries and with absolutely no obvious injuries, which
mm.
makes it really challenging because it's like, how much do I need to do? Like, how much should we do or not do? What are this person's goals? So it makes it tough. Yeah.
Yeah, absolutely. Yeah, well, that leads me into my next question, which is, what got you interested in folks with
Yeah.
dementia as an ER doctor?
Yeah. Yeah, so I have lots of personal experience. My grandmother lived with us when I was a teenager for a few years, and then as an adult, as a doctor, I've helped some family members navigate situations like getting a diagnosis, like struggling to get a diagnosis,
Mm,
and having some combat from medical professionals because someone's like a little bit paranoid. My mother-in-law's her mom was paranoid and accusatory
mm,
and not in front of the doctor, but towards her. And
mm.
she was diagnosed eventually with vascular dementia. And so I kind of helped her with some of the issues that came up until she passed away. And so it's been personal stuff, but then also honestly, what I see in the ER just is really frustrating.
Mm.
I want people to receive the type of care that they would want, that they would choose for themselves if they were capable. But what I see inside of healthcare is this big gap, and there's no one really talking about how do we figure out what's okay and not okay before stuff happens so that people can process this when they have the mental space to do
Yeah.
so. When you're in the ER and we're asking you, well, what do you want to do? Do you want to stay in the hospital? Do you want to go home? A lot of people just default to the standard of care, and whether or not that's what's best for the person, it should be individualized. We shouldn't do everything based off protocols, which is what I'm seeing because we're so busy.
Sure.
And so much frustration. I see so much stress and from caregivers, decision makers, not knowing how to choose. And so I was like, well, I can teach them how to choose. So that's why I decided to come online.
That's amazing. Yeah, and I agree with you. It's so, so important to have at least a crisis intervention type plan that might involve getting the healthcare system engaged. You guys tell me in chat if you can relate to maybe you had like a really intense argument, or sometimes folks with dementia, one of the symptoms is they can get more aggressive. They can get kind of scary. So it's good to know what to do if that type of stuff happens. So yeah, I'm curious, like what kind of crisis intervention type stuff do you teach people seeing this type of stuff in the ER?
Yeah, so I mean, I tell people that I always try to educate the nurses too that we have to be slower, we have to be calm, we have to control our own emotions. We can't meet them where they're at with how they are. It's not their fault. They're not. So I mean, it's very situationally dependent. But I'm always trying to de-escalate and be like, just give them a moment, stop touching them, like leave them
Yeah.
alone. They're not actively dying, so let's all take a beat. So it really depends on the person, but and I don't like to use medications unless I
Mm.
absolutely have to if there's a safety issue. But it's really tough. I work in freestanding emergency departments too, and so sometimes when people need to be transferred to the hospital, they've been in our ER all day. They've kind of like calmed down and gotten used to the surroundings, and then we're having them get on an EMS stretcher and go with the medics to an actual hospital, and the situation can get really, really heightened. So it's a lot of like education about this person's not doing this intentionally. Let's all remember that they're living with dementia. But it's not easy. And sometimes we do have to medicate people in the emergency department.
Sure. Yeah, Vita Bella says this touches close to home. My mom goes from quiet to being so afraid, and yeah, that's super super real. Truly, that's I would think when you see folks that are combative or who are just freaking out, it's because they're terrified of where they're
Yeah,
at.
I think that's a big part of it. I mean, and then people can truly be altered and have like delirium or worsening confusion because of a medical problem. And we can't forget about like untreated pain. And
Mm.
I feel like a lot of times people are trying to communicate that they need or want something, but they maybe don't have the language skills anymore to do that. And then we're so fast paced,
Mm.
we are like, come on, spit it out. Tell me what you, and a lot of times we don't realize the person's living with dementia in the earlier stages
Mm.
sometimes. So I think the more people can do to like learn the expectations of the symptoms of the illness and then the strategies that work for their person. I think people like you online who are teaching how to handle behaviors is one of the most important things for decision makers and caregivers because it's a day-to-day stressor and frustration. And so learning these skills, and none of us are born with them. So
Oh yeah,
it's a whole new language and a
yeah.
new way, a new thing you have to learn. So it's so important what you guys do here online.
Oh, well, thank you. And I'm curious as well. So I think a lot of caregivers would definitely love to know how can we communicate with medical professionals like yourself
Mm-hmm.
to help advocate for our folks with dementia, to help them get the best level of care, because sometimes that can be
Yeah,
frustrating too.
it is really frustrating. So, I mean, I'm biased. I'm a medical professional. I've been a full-time ER worker for 10 years. So, my number one thing is to like be nice and to just like say thank you. And like, I know you're super busy. I always tell people, like the people that I work with, my clients and people that I meet online, like just kill the staff with kindness. Like it's frustrating sometimes, but always be the bigger person. And when people are nice, like we want to come back, we want to do more. Like that's the kind of people that typically go into healthcare. There's a lot of burnout and there are bad eggs. Like
Sure.
that is a thing for sure. But I also think, so that's one thing, but I also think the more organized and prepared you are, the more that you can like summarize and tell us like what is it that you're trying to get out of this? Like what specific questions do you have? What concerns do you have? Like just tell us straight up especially in the emergency department, like what it is that you're wanting out of this visit. That can really be helpful. And then having a list of medications, like knowing a bit about your person's medical problems. And honestly, like what I tell people is that the medical decisions that you all are going to have to make are foreseeable. The
Mm.
timing of them, maybe not so much, but the medical stuff that's going to happen is foreseeable. So you can like learn about what's most likely to happen to your person based on their individual health risks and have kind of an idea of what their overall goal of care is are we trying to prolong life? Are we trying to protect quality of life? Or are we trying to focus on comfort? And that's kind of like that's like a big picture thing. So, but for each person, we want to make individualized decisions. And so you might have to repeat yourself and just be prepared and be nice. And I feel like those are kind of the biggest tips I have.
Yeah, absolutely. Absolutely. So, um, as far as like crisis planning, so let's say
Mm-hmm.
you do need to take your person with dementia to the ER. Like, have you seen somebody like ever hand you like a card saying like, "Hey, my person has dementia"? Has that been a thing
Yeah,
before?
I've not seen an actual card. People have showed me on their
Oh,
phone.
oh, yeah. Oh, that's a good
Yeah,
one
so
too.
they have like a note typed on their phone and have showed me. I'm also extremely attuned to this now
Sure.
because I've come online to do this. So I am like sometimes going to family members and saying, "Hey, I kind of am worried that your person might be living with dementia." Like, and sometimes I'm the first doctor that's ever said anything or mentioned it to them. But yeah, I tell people like make sure if your person's in the earlier stages and mentioning dementia is going to escalate like the situation, some discreet way to tell us and to tell us that your person has trouble making their own medical
Mm,
decisions. If it's true that they have lost the ability, that they don't have capacity anymore, then tell us that. And you don't have to have a medical power of attorney form in order to make medical decisions for someone living with
oh,
dementia. It
interesting.
depends. Yeah. So every state has its own like legal next of
Mm,
kin. So we don't need a piece of paper. We need a general consensus, and sometimes there's only one person. So it does get trickier when there are multiple people, but that brings up like a lot of points. I could like elaborate on a lot of things.
yeah, yeah, definitely, definitely. So, yeah, when like so I know you touched on this a little bit earlier, and you guys can let us know in the chat as well, because it's not just us talking. Like we're happy to have everybody be in this conversation, but um, it's something I call Showtime, which is
Mhm.
that person with dementia is acting wonderful for you, but they act terrible for the people taking care of them. So like how would you communicate that as a family member to your medical professional that like you're like what she's saying is not true.
Yeah. So that is absolutely true. I mean, the way that I think about it too from a medical standpoint is it's like a stressful event to go see a doctor, and a lot of us really like we all do this. We naturally like pull ourselves together when we go to see doctors. So like we use our brain's energy to really focus. So I think it's very common that that happens. It's normal, I think. Um, and it's going to be more difficult to navigate how to communicate when the person's in the earlier stages and they're still aware of what you're doing and what you're saying, and they want autonomy, which they should have autonomy as much as possible. So I think that sometimes it can be helpful to write out what you've seen, and the things that you're concerned about and organize that. And also come at it as a way of like, listen, I want what's best for this person. Like, I love them. I care about them. I'm trying to help them. And like, I want you to understand what's going on so that you and I will be on the same team and that we can
Mm,
help. Like, I care about this person because medical professionals are taught to talk to the person and ignore
mm,
everybody else. We are taught to kick people out of the
mm,
room to
mm.
talk to the patient because we're supposed to protect their privacy.
Sure.
And this is a very gray area because we do want people to still be able to weigh in and participate, but they don't always truly have capacity. And oftentimes it's easier for families to realize that than it is for doctors. And
Mm,
so in an office setting, it's really important to it's really important to like document this kind of ahead of time.
Mm,
And even if you can present it to the office before the visit so the doctor could
that's
potentially
smart.
review it. And also I'll say like you might want to consider, this is like the perfect world, but like who your person sees, the physicians that they see. If you have any control over it, like ask, do you see a lot of people living with dementia? Do you
Mm,
understand what it's like to be a caregiver? Like, do you understand that I'm going to be coming at you and like telling you things, and we have to respect autonomy and privacy, but like I know what's going on and I just want what's best for my person. Like the more upfront I feel like you can be about that, the better. But it's harder in the ER.
mm,
So because like we don't know you, you don't know us, we don't have any relationship. So I do think it can be helpful to use terms like, if it is true, my person has lost decision making capacity. I mean, don't lie about it, but like my
mm-hmm,
person has lost decision making capacity. Like I am their medical decision maker.
mm,
And if you do have documentation, you can say, like, I do have documentation that they need me as their medical decision maker, and whatever that document is called in your state. And like I have been making their medical decisions. Like I've been doing this for a while, you know?
yeah.
So
So it sounds like the documentation's a little bit more pertinent in an emergency situation versus like an office situation.
it really depends because I mean, I don't need a piece of paper to I don't need a piece of paper to make medical decisions. I
Mm,
need someone who knows this person, who has a legal right to make their decisions. So, a spouse that they're not in a divorce with, children, and then sometimes it's like siblings, you know, not usually a living parent, but each state has its own hierarchy, and it's normally if there's a guardian, that's
mm,
first, then it's a spouse if they're not divorced or in some sort of issue with that, then it's adult children, then it's their parents, then it's their siblings, blah blah blah, down blood relation.
mm,
So, and if I have family and they're in agreement on things, then we can make decisions without any paperwork. Like I know that that person doesn't have capacity right then when I'm seeing them, that they can't make decisions. So it is a little bit, I think people get nervous about being a medical decision maker and stepping into that and taking ownership over it. And if you don't do that, like what will happen is you'll just you'll get conservative care. You'll get care that's focused on prolonging life
mm.
and protecting quality of life and in the hospital, like, you know.
Sure.
So, and that might be the right thing. But for some people, it's not what they would want if they were able to choose for themselves.
Yeah. So, like, what kind of medical decisions do you see folks needing to make for their folks with dementia the most often?
Oh, oh gosh, I mean, so there's routine stuff like there's routine stuff like say someone fell and it's okay. Well, no one saw them fall. So did they pass out? Is there a medical reason why they fell? So now we're making decisions about what types of tests we should do to try to
Mm,
work this up. Like, should we go chasing whether or not there's a medical issue that caused them to fall, or do we think it's probably likely that they tripped and fell or whatever? You
sure.
know, that's one thing. When other medical problems happen, so just because a person's living with dementia doesn't mean that they're not going to have other medical problems. So how do
Sure.
we manage problems with the lungs? Like they have pneumonia and they're having trouble breathing. How do we manage if they have underlying congestive heart failure or heart problems or kidney problems? How do
Sure.
we manage if they have cancer? Should we go looking for cancer? It's every medical decision that we would have to make for ourselves, plus the things that happen to people as they're living with dementia, because it's a disease that's affects, well, it's not a disease, it's an umbrella term for all
Sure.
different diseases that cause the symptoms, but the brain and the body are connected. And so naturally there's other things that happen, like swallowing issues and mobility issues and incontinence issues. So but those are more towards the later stages. In the earlier and the middle stages, we're making medical decisions just like we would make for ourselves. Like, so but it's more complicated for a person living with dementia. We really have to make individualized decisions because coming into the hospital and having testing done, you know, it's not always in the person's best interest, and hospital stays have risk associated with them. Person's off their medicines, they're not sleeping, they're in a different environment, they may get medications that they, you know, wouldn't need for sedation to keep them in their bed because people don't have the time to redirect them. So I advocate that people plan for the decisions that they are most likely going to have to make on behalf of their person because of who their person is as an individual, the medical problems that they have, what they're at risk for, and what happens because of diseases causing dementia. That's what I teach people to do.
Sure, sure. Yeah, of course. Yeah. So I know it's just it can be so stressful when you're just trying to rush them in or things like that. So, uh, what should family members know as far as like getting them to the ER? As far as like I don't know if maybe you're as familiar with that since you're already at the ER, but
Yeah,
like
I think go ahead,
oh
continue.
sorry, like so if there's like a crisis like for example some of the like I've my background is in Jerry Psych, so oftentimes things will come to a head where and I don't want to scare anybody, this isn't a very common thing that happens with dementia, but it can happen to some people where they just become so agitated that they're like punching or they're
Hmm.
trying to throw stuff at you. Like you feel like your health and safety is at risk
Hmm.
being with this person with dementia. So oftentimes I'll tell them to call 911 and
Hmm.
to try to get them to the ER. I guess
Hmm.
what are your thoughts as far as like what would constitute like a crisis that would get them to the ER for
Yeah,
that help?
definitely a threat to their own physical safety and the physical safety of the people around them. That is what we are there for. We are fully equipped to handle that type of situation. And to be honest with y'all, most of the time, if it's like that, when someone comes in, we can't get vital signs on them. We can't see what their heart rate is. I don't know what their blood pressure is. I don't know if they have a fever. I can't take care of them at all until they're medicated. So those that's called excited delirium, agitated delirium, presumably.
Mm.
So yeah, I mean that is they are potentially yes, you have to come to the hospital. You got to come to the ER for that. So it's okay. I do think that sometimes de-escalating before that situation, which is what you teach people how to do, which is what's so important is that people inside of living facilities and the staff inside of living facilities are trained in how
Yes.
to interact with the person so that these situations happen way less.
Oh, for
Um,
sure, for
yeah.
sure. Yeah. I know the one that my facility did was like a crisis intervention prevention training where there's like even specific like holds that you'll do
Hmm.
to make sure that they stay safe. So um it's hard for me in good faith to suggest that to family caregivers because those tend to be very expensive and honestly geared towards facilities. But I mean, essentially, what's there is, if you're trying to get them to the ER, what you want to do is you want to make sure to call
Hmm.
for backup so that there's other people, other trained professionals that can help you with that crisis. But beyond that, let's just say that isn't possible and they're just telling you on the phone, like, you just need to get to the
Hmm.
ER. You want to make sure that they're calm. So, like, stay at least out of striking distance, is what I
Hmm.
call it. And just, yeah. So, I mean, like, that, anyways, that's more my experience dealing with someone who's going through a crazy agitated moment
Hmm.
before you
Hmm.
can get them to the hospital. Like, I wouldn't try to transfer them when they're in that, like, crazy agitated
Hmm.
state.
Hmm. Yeah, I think you have to take care of your own physical safety.
Yeah.
And if you need to call 911, like there's a whole bunch of people that are going to come and help. So it's not very common though. Like you
Yeah.
said, I don't see that very often.
Yeah.
So really, I don't. It's pretty rare. And a lot of times when I do see that, it's a medical problem. So there's a
Interesting.
medical issue. Yeah, it's almost always when I see that because I do think that a lot of places do a good job at keeping people safe where they're living and de-escalating, you know.
Yeah, definitely. Oh, good question, Debbie. She says, how do we handle making them aware that they are forgetting stuff and that we are just wanting to help them and not judge? Yeah, that's a great question. So, like, let's just say you're trying to share with your medical provider details about their health and they're just like, "Hey, butt out." Like how
Yeah, I
what do we
think
do?
this is a prevention is key kind of thing.
Mm,
And I think
okay.
that you have to anticipate that that's likely going to happen or it may happen. And so
Mm,
like already maybe have something written down that you can pass them. Or if it's in an office situation, tell the staff at the front desk, tell the nurse, bring multiple copies of this document in case they don't give it to each other. Because everyone thinks that we talk to each other. And I mean, we just don't. Like, we don't always get to talk to each other in the emergency
Mm.
department.
Oh,
So like
interesting. Okay.
someone meets you in registration and then they write some stuff, and then someone meets you in triage and they write some stuff, and then the actual nurse who's going to be taking care of the patient sees the patient, does like a much more assessment, and then the doctor and PA comes in. Well, at any point in that process, someone's doing something else and we don't talk to each other like down the line. It's
Mm.
so, in the same kind of thing can happen in a doctor's office. So I think that I think you could say something too in this situation, like, I mean, I don't know if the doctor's going to know what anosognosia means,
Yeah.
but anosognosia is a lack of insight or awareness into the fact that you're living with a condition, which is extremely common for people living with dementia.
Sure.
So, I mean, you could drop that term and your person might not
Oh,
know, you know.
oh, that's smart.
Um, and you could also say, like, we're dealing with some capacity issues there, and I've been helping. And, you know, I think it's harder though when you're trying to backpedal, and for that, it might just be being more assertive and being like, I really got to stop you. And like, or like, hey, I don't know if you can make an excuse and say, you know, I forgot something, I've got to go. And then like maybe gesture at them to go into the hallway. Like, I've had people point at me and then point at the hallway. And I'm like, okay, well, I know what that means, you know, and I'm out in the
Okay.
hallway talking to them. So, I don't know. It's just there's lots of different strategies, and it kind of depends on like office versus hospital, and then like, do you know these people or not? And
Sure.
like how much time did you have to get ready beforehand?
Sure. Oh, that's a good question, Debbie, just in general. How can you explain what sundown means? I have
Hmm.
to figure it out so I can explain it to my family. So, sundowning isn't like a diagnosis. It is basically dementia symptoms getting more intense as the day goes on. So think of it almost like their brain's getting tired, and it just means like whatever things happen to, like, usually what you'll see is like a lot of anxiety, a lot of agitation. Like, I'd say most anxiety and agitation are the main things you'll see with sundowning, but it differs from person to person. So that's the general thing. It's just their symptoms of dementia are just getting more intense as the day goes on, as their brain gets tired. So like sometimes people will say like, oh, my person sundowns in the morning. And it's like, usually that's maybe they didn't sleep very well the night before. So it's still their brain being tired. Um, yeah, I don't know if
I,
you have
I
two
think
cents
that's a
about
great way to,
sundowning.
that's a great way to explain it. And people in the earlier stages, honestly, you may not even know the person's living with dementia earlier in the
Yeah.
day. And then
Oh, yeah.
later in the day, they're confused, they're repetitive, they're asking, you're just like, oh, like something's not right with you. I've noticed that in the emergency department.
Mm.
And then I've had, the one thing patient I can think of is someone who fell at home, told me the whole story in perfect detail.
Wow.
I ordered the appropriate tests. And then I had to do a CAT scan because there was an abnormality on the X-ray. And so she was
Mm.
in the ER for a long time because it takes longer to get a CT. It wasn't an emergency. It was just, we needed to make sure she didn't have a small fracture and that she could go home. So she was in the ER for like 6 or 8 hours or
Wow.
something. And then her family came and she was a completely different person. I went in the room and I was like, oh, wow. Like, and I said to her daughter, I'm like, does this happen? Like, are you concerned she might be living with dementia? And she's like, yes. How do we get her diagnosed? So it can be like that too. It's just that you realize that there's something is wrong, with the way that they normally function cognitively towards the end of the day in the earlier stages of disease sometimes.
Yeah, yeah. Um, Dr. Lean, I'm sorry if I'm saying your name wrong. How do you manage when they have very limited speech?
Hmm.
So let's just say maybe they're in the later stages. I mean, at least what I would suggest is getting a communication board. So if they're very limited, that can help them with like basic needs. So they can just point to more like a picture if they're in the latter stages. But I mean, just keeping it as simple as possible, and sometimes just straight up taking them. Like sometimes I don't even ask. Like sometimes they'll be like, "Here, come with me," and I'll just guide them to the bathroom, and I'll just be like, "Here, let's just try." So it's like you do. Interestingly enough, it's less explaining.
Oftentimes that is like a barrier where if you ask them, hey, do you want to do such and such thing? The answer is always no. Just the answer is always no. If you ask them if they want to do something, because their brain's trying to pick the easiest thing. So it's always going to be the path of least resistance. So I don't know if you have any thoughts about the limited
That,
language.
that's tough because I would love to know like more context around it. Like,
Yeah.
but I do
Oh,
think
yeah.
that I do think sometimes having a speech language pathologist, like considering an evaluation to see, but occupational therapy, speech language pathology, like someone like you to come in and see how to better communicate, with the person. I think sometimes people don't realize that there are other services that are um, much better than doctors, much better at doctors that helping people manage the what happens when people are living with dementia. We're not trained in it. We're not. So
And that's
you're
a
not going to
huge, huge,
find.
huge misconception. I know that, like, so what resources do you usually suggest to folks? Because I hear a lot of frustration from caregivers saying, like, my doctor didn't warn me of any of this. It's like they almost expect their doctor to be this, like, expert on everything about what they're about to go through, and it's just not the case.
Yeah. I mean, I tell people I mean, it depends on how tech savvy they are, but most of the people who find me are online. So, I mean, I give out like people like you, people's resources. I say go to YouTube. There's lots of good education on YouTube. I mean, Teepa Snow is like an original person that's done this. And so learn online. Like I tell people, like, unfortunately, it's just not what we do. We're not trained in it. And occupational therapists, speech language pathologists, people who work in Jerry Psych, neuropsychologists, occupational physical therapists, speech language pathologists, all of these people are like intimately involved with caring for people living with dementia, like creating plans of care for them and actual interventions that can help on a day to day. We are here to make sure, well, we're here to diagnose medical problems and to treat them and to prevent them from getting worse and to protect quality of life and to keep the person alive. And I think people need help with setting goals and what we should do and not do. And I think a lot of that comes in being educated about what the treatment looks like and what care actually looks like from a medical standpoint. But anyway, that's what I tell people is like, you're not going to get that information from a doctor. So you're going to have to learn online now. And I think there's a lot of burnout in all of these people. I've said we all got so frustrated inside the healthcare system that we're like,
Oh,
okay,
yeah.
we're going to come online to teach people because no one's getting this information. So,
Yeah, I mean, I think a big point of frustration is that there isn't a one-stop shop you can go to because there's just so many different domains
mm,
of different types of professions that you would hit.
hmm
Like I know for at least for me personally, I have gone into multiple categories of like jobs you could have within like the senior industry,
hmm
in order to better help people understand how to both navigate the system and to deal with the challenging behaviors. But I mean, realistically speaking, on your caregiver journey, like you will see neurologists, you will see ER doctors like yourself if there's like falls or medical emergencies or things like that, which can be, if especially if you're a person with vascular dementia, that's a very high possibility. You could be seeing a social worker and trying to navigate Medicaid. You could be seeing a lawyer to navigate all the financial pieces. You could be dealing with senior living stuff for memory care. It's just like it is impossible to be an expert on absolutely
yeah,
every single step
yeah.
of the way, which is why I think there's so much frustration of like, why isn't there just the one dementia expert that rules them all?
Yeah, it's because no one can be an expert in all of those things. It takes like a true village, and the support of a person living with dementia is very complicated, and it has to be individual. Like it has to be an individualized approach because you have their financial situation, you have their family situation, you have the dynamics in that family, you have who they are as a person, what their background is, like how like what their level of education is, like there's so many things, where they live in the country. So it's really, really tough. I just do think that things are gonna get better with more and more people coming online. So, um, to help.
Yeah. Yeah, absolutely. And I know at least what I do, I know I was before you hopped on, I was talking about the workshop I'm hosting about challenging behaviors. But I mean, ideally, what I'm trying to do is create resources to make that whole process a little bit easier and refer to other resources that I'm not obviously an expert on,
Yeah.
as well, just so you don't have to go looking around as much. So
Yeah.
yeah, anyways, if you guys are interested in the workshop that's happening on Zoom, September 17th through the 19th. The link is in my bio. I know we're getting we're a little bit over our time, so I guess before we go, are there any last thoughts you'd want to share with caregivers as far as like making medical decisions or emergencies or things like that?
Yeah. I just want you all to know that the decisions that you are most likely going to have to make are foreseeable and
Mm,
that there's support out there to help you. There is a kind of a process and a plan that you can follow as your person's decision maker. I'm working right now on, I have a checklist that I offer that kind of goes through the steps that everyone should go through if they're someone's medical decision maker. And I'm
mm,
going to be releasing that on my social media soon. And I have this like mini course that I put together that's going to be a lower price than my like bigger course because I individually help my clients. And I think that will help people get into how to make an actual plan and how to think about what their person's at risk for. But I think that you all need support in the day to day, and like you've got to get help with the day to day stressors and friction and have things be more stable. And then when you're ready to get support and like learning about what might happen to your person from a medical standpoint, I'm here as a resource for you. I have a ton of free help. Like you don't have to become a client of mine. You can consume my stuff and you'll learn so much for free. So yeah, you should sign up to connect with me via email. It's blammd.com/email if you're interested in like getting my emails and coming to my, I also do live Q&A sessions. So
oh,
those are
there you go.
free. Yeah.
Perfect.
So
Awesome. Well, thank you so much for your time. And man, it's always good to know what you're just what to do in those situations that are stressful as caregivers. So, anyways, thank you so much for joining us, and yeah, hopefully we'll see you soon.
yeah, I'd love to come back anytime. If you guys want to deep dive into something, I'd love to do it. So just let me
Yeah,
know.
yeah. Let us know in the comments. All right, all right. I hope you guys have a great night. Bye, everybody.
Bye.